Hey guys, my name is Sam. I'm here with my partner Skinny Medic. We are on episode 65 of the Civilian Medical Podcast, and today is going to be kind of a hodgepodge.
Yeah, definitely. Kind of have some short topics we want to cover and just kind of think about some random things that are popping on the internet this week that we wanted to talk about. I mean, it's crazy to think that this is episode 65. We've been uploading our old videos to our YouTube channel, and like I'm on episode 30 something, and like I'm putting the dates in as like 2019 to January 2020, February 2020, or 2020, and I'm like, man, this is before COVID. Like this is when things were normal, and so it's kind of been going back and like watching like the old episodes. I'm like, they were terrible, but people still subscribed and people still listen. So good for y'all.
Yeah, I'm sure we'll still have some terrible ones out there
Y-
periodically moving forward.
Yeah, definitely. Like, oh, that was a bomb, but every 1 for 10, we'll be fine. We'll get a good one in there every once in a while. So keep subscribing to the podcast and keep supporting us. I would appreciate it, even through the bad times.
Yeah. So today, before we start talking about, we're going to talk about the nurse going to jail for a medication error, why knee drops aren't a thing, maybe some other videos and stuff that have popped up that need to be addressed here. But before we do that, huge thank you to our sponsor, Primary Arms. They carry a bunch of ballistic helmets, Team Wendy helmets in particular, I really like that are up on the site. I use a Team Wendy ballistic helmet. I think it's an X-Fill for my everyday use, and I freaking love it. So you can go over to their website, check it out. They got a lot of stuff up on their website, from helmets to armor, weaponry, of course. So go check it out.
Yeah, the one of the things I need to pick up for my helmet is I run night vision on it sometimes, just when I want to be the cool factor, and I do not have a counterweight on there. So I was doing SWAT training, I guess last month, and we were doing like a movie theater, and I was just kind of having fun with the night vision. And I'm like, one, it hurts my head. I'm like, holy crap, this thing is heavy. This sucks. I'm too old for this. And then the counterweight, like it always wants to keep dropping down. So I need to pick up a counterweight for my setup.
I've got like three. I bought three for my helicopter helmet. We've got the dual tube night vision, and I have one I keep in my bag, but I've just farmed it out to my partner and the pilot every shift, because up until then nobody like knew what a counterweight was or how it worked, because night vision's not what we primarily do, and it's amazing the difference, to the point where now one of the pilots has stolen my counterweight and I can't get it back. So
Nice.
big difference when you're running night vision for sure.
Yeah, I got to pick it up. Like I said, Primary Arms has been stock. So if you're looking for something like that, you want to improve your setup, I would go over there.
So the first thing we're talking about today, we are going to be talking about the Vanderbilt nurse, RaDonda Vaught, that just got convicted of I think it was negligent homicide, for killing a patient in pretty horrific ways. But I personally don't think that this really rose to the level of criminal negligence, or that she should have had that conviction or had criminal charges brought against her at all. Um, what's your take on that?
So to give a little background, make sure I've got all my information correct. You can correct me if I'm wrong, obviously. So she has a patient that needs Versed. Versed is a sedative drug. We can use it for lots of things, for sedation, for seizures, multiple things Versed can be used for. It's a fantastic drug. Uh, it has its side effects, but overall is not a terrible drug to give. So she goes to a drug dispenser. It dispenses medication. You're supposed to, of my understanding, you type in the patient's name, the drug. There's a couple of checks and balances there to make sure you're getting the correct drug out. From my understanding, she overrode those, reading a couple articles, and she ends up getting correct?
Yeah,
Vecuronium?
Vecuronium. Yep, and Vec is a paralytic, another great drug when used in the right way. But it's used in like rapid sequence intubations, people that are have a breathing tube in. It just makes it so all your muscles go flaccid. You can't even breathe for yourself, but you're completely conscious. So it's a really scary med. It has to be mixed with a sedative. So then what happened?
So, yeah, so she uh, gives gets the wrong drug out of the machine, delivers the wrong drug, and then apparently does not go back and reevaluate the patient due to staff shortage, whatever the reason was,
Patient
overload.
was going into a CT machine.
Okay,
So they thought they were sedating her just a little bit for the anxiety. They put her in this or MRI, CT, MRI, I forget which one it is, but they put her in a donut of some kind that's giving magical answers.
okay.
And in the course of that, she stopped breathing and had a hypoxic episode where her oxygen levels got really, really low. I don't know if she actually went into cardiac arrest in that moment, but then the patient sadly died a couple days later in the ICU after a head bleed caused by a severe anoxic brain injury, so lack of oxygen to the brain.
On the patient side, like this is not the way you want to go out of the world.
No, it's horrific. It's
Not be able to
horrific.
breathe, like, you know what's going on, you just can't breathe. You can't tell your lungs to do anything. You can't tell your diaphragm to drop down. This is not the way that I'd wanna go out of this world. So a couple of things is, was I would like to know how many shifts she has been working. Was it overtime? What was her patient ratio? Like, did she have 4 patients, 5 patients, 1 patient to consider? This is all stuff I don't know the answer to. I'm being perfectly honest with you, but I don't think she should have went to jail for this. And I mean that may be controversial, but I don't think she. I think she should have lost her job, and I think she should have lost her nursing license, where she's not can't be a nurse anymore. But I don't think she should have go to jail for it.
Yeah, so I'm of the same thought, and I think for a lot of people that are not in healthcare, this seems like an odd stance to take for something like that. Because after all, you fall asleep behind the wheel and you kill a school bus full of kids, like you're probably going to go to jail with some criminal charges at some point. But in this case, it's a little bit different, and there's a couple things about this case that I think for background also need to be discussed. One, this happened in 2017. This happened a long time ago. She came right out. She admitted her mistake, as we are all supposed to do with medication errors. I've made medication errors, nothing quite as catastrophic as that. I know Skinny Medic probably has never made a medication error in his life, but it's actually a pretty normal thing for healthcare providers to do. So she came out, she admitted her mistake. She went to the hospital, and one point I'm not totally clear on. I know she separated from Vanderbilt. I don't know if that was a asked to resign or if that was a choice separation on her part. She went in front of the Virginia State Nursing Board, and they basically declined to look into it. They're like, no, it's okay. It's a medication error. Those things happen. And they sent her out, and she actually worked for a year as an RN at a clinic just down the road. And it wasn't until CMS, which was doing an audit, and they're basically a financial group that looks for, I always get these mixed up, but like Medicare, Medicaid, and they were doing an audit of Vanderbilt, and they found this. The family had already forgiven the nurse. They had this public thing. The family came out and was like, you know what? We get it. You messed up. You admitted it. You're sorry. Like, we hold no grudge against you. We're not pressing charges. We're not. I don't think she even had a civil suit brought by the family. I think there was a settlement from Vanderbilt out of
Dang.
court, but I think the family was pretty like, oh, it's okay. Like, we understand. And it wasn't until financials got involved that she was charged criminally. And then all of a sudden, the nursing board decided to look into it, and then she lost her nursing license. And then criminal charges were brought, and she came into all of this. And then eventually she was convicted um, of it. So I think there's a lot of facets to this. And now coming back to like the actual mistake, number one is quick Google search can show you the number of times that vecuronium has been given on accident to a patient. And it's happened a lot. And as far as I know, none of them have resulted in criminal charges. This case suffers a lot from outcome bias. The patient died in a horrific way, and therefore we look at those actions differently than the same mistake being made by a different nurse that the patient happened to live. When in actuality, that's not what has to be like considered in a lot of these cases. It's very, very rare to have a criminal negligence case. So a lot of things happened. For the override portion of it, she did override safeties. However, the Pyxis machine that she was drawing the meds from was being updated, And there was actually emails from Vanderbilt saying, hey guys, you might have to override some meds. So
Oh.
usually the doctor puts in an order, and then that goes to the patient's chart, and then the nurse can only draw the meds that the doctor specifically ordered. This had to be an override, and meds were overridden like 25 times in the last like 3 days for this patient. And she went to it and had to override that med, overrode it. She bypassed a bunch of safeties. She didn't look at the med. She messed up. But ultimately, there were a lot of failures beyond just her failure that resulted in this patient's death. But I mean, you and I were talking before the show, like, why do you think this will be harmful in healthcare in general?
So, like you said, I have had medication errors. I'm very like I have not killed anybody because of medication error, but I have over sedated people. Kind of think about a couple of things. I'm like, man, I gave too much etomidate one time, completely over sedated. Now, I had RSI'd and I needed the sedation post intubation, and so basically, I just over sedated someone who already had a breathing tube for them. Not a huge deal, but it's a medication error, and it honestly ticks me off that I'd made a medication error. I was a field training officer at the time and supposed to be better than that, and it ticked me off that I made a medication error. Uh, Hypothetically, maybe certain paramedics working on the ambulance recently, and I may have had a seizure patient that needed Versed, same drug we're talking about here, and so I pull the drug out of our narcotics box. We're driving down the road. I hand the vial through the cab of the truck because I want to make sure I confirm I've always done this. It's like, hey, first said 5 milligrams, correct? Paramedic looks over, goes, yep, first said 5 milligrams. Like, sweet. So give the patient 5 milligrams, we're done. I come out of the truck and the paramedic I'm working with was like, hey, where's your waste at? I was like, I don't have any waste. And he was like, Dietrich, that's a 10 milligram vial and 2 mLs. And I was like, no, I gave 5 milligrams and 5 mLs. And I was like, I checked my drug dosages. And he was like, I don't know. And like, I have a panic attack. I'm like, I'm gonna have to walk back in there and tell the doctor, hey, I instead of giving 5 milligrams of Versed, I actually gave the patient 10 milligrams of Versed for their seizures. I double dosed them. So I was like, no, I gave 5 ml. So I ended up digging through the trash, found my vial. I was like, yeah, see, whew, it was the last vial that was actually 5 milligrams. So I think as new paramedics are coming up through here, like this is important lessons to learn is the six rights. Like we learned the six rights for a reason. For me, like I always get even if I'm working with the EMT, I'm gonna get them to double check the drug, make sure I'm giving the right drug. That's not just a brown box, not just a purple box. Like it is really the drug that I'm trying to give. And I think because we've seen this go through the court system, how it did, I feel like we're going to see a culture where I don't tell anybody that I screwed up, that nurses won't tell. They won't come forward because they're afraid not only they're going to lose their job, but they're possibly going to go to jail and mess up their family, things like that. So I think you're going to see a culture of stuff get swept up under a rug more than it already is.
Yeah. And this kind of touches on just culture, which is a concept in healthcare, really heavily in nursing. It's starting to come into paramedicine where it encourages you to report things that happen because ultimately more people like med errors are going to happen no matter how, like you could sentence people to death for a med error and med errors would still happen. The difference is do people come forward or not? It probably would have come to light anyways, but RaDonda probably could have been like, no, this is an adverse reaction to Versed, like it's all normal. And then they would have treated her wrongly and could have resulted in more harm. So the med errors are going to happen regardless. The thing we can do now to help mitigate the damage from med errors is to make it so that they're super reportable and that everybody feels safe coming forward with that. Because if we know, like, it's kind of like I've backed into things with the ambulance, and I know that if I come forward with that accident right away, and I'm honest about it, and I own up to the mistakes I've made, I know it's fine. Like they'll slap me on the wrist. They'll be like, "Hey, man, have a spotter." Same with the med error. They'll be like, "Hey, RaDonda, you need to go to some different training. You know, you need to do some different things." But ultimately, she feels comfortable coming forward. And if you don't have that, now people are sweeping it under the rug, and we're going to have patients going into all of these weird metabolic processes and having these weird reactions. Everybody's scratching their head like, wow, this is a really weird thing. We need to do this, that, and the other thing. And in actuality, it was just a wrong med, but nobody's fussing up to it. In nursing, it's a little bit harder to sweep those things under the rug. I believe, like, and the honest truth about paramedicine, though, and in the ambulance, unless you're super advanced and you're like drawing meds from an electronic thing, there's not much med tracking.
Yeah.
For your controlled substances, yeah, there's tracking there and it's a little bit harder, but like, let's say you give the wrong antidysrhythmic, there's really nobody that can come in and say you gave this based on this par level. I'm not pulling it from a machine, I'm pulling it from a pack,
Mhm.
and pushing it for the patient. And I'm usually alone in the back of the ambulance. So if I wanted to, I could hide med errors every day till Sunday. And I don't, and I will not. Uh, but that does change. Like if you know you made a med error and it killed a patient, and you're facing 12 years in prison, I'm guessing most people are going to lie about that because that's a long time, for kind of a ridiculous case. So what we have to look at is, who does this conviction help? It doesn't help the family. They didn't want this conviction. They didn't want her brought up on criminal charges. The patient's
Doesn't change the
dead.
outcome either.
No, the patient's dead regardless, and that's tragic. The patient died in a horrific way. The nurse didn't wake up and go, "I'm gonna kill a patient." She's never gonna be a nurse again, regardless, and I'm with you. I think it's okay that she lost her nursing license. I think it's okay, that she was fired and all of that stuff. Some people don't, but I think that's A-okay. But it destroys 2 lives at this point. So we have the dead patient, and now we have a woman that really wanted to do good and messed up. Maybe it was laziness, maybe it was just a honest mistake, maybe it was training, maybe it was just system issues, but regardless, now you've destroyed her life for 0 reason, and we're getting nothing for this criminal case except for, more taxpayers' money going to a court case. Um, so I can't get behind the criminal conviction for her. We have to be responsible for our actions, but that criminal conviction is going to cause people to leave the profession. It's not going to discourage me from doing a med error because I'm already careful and I check my stuff and I still make mistakes, and so do other people. I think statistics right now are 1 med error per hospital per day in the United States on average.
Yeah, I'm surprised it's not a lot more than that, honestly. But like you said, though, like in the back of an ambulance, you can cover it up. Like if you're not the super honest, like integrity, like there's lots of that comes into effect there. But I could cover that up. Like my automodate, not automodate, my Versed they're talking about. Yeah, I could have easily covered. But I, be perfectly clear, I did not make a med error. Don't come after me. But like when I did uh, give too much accommodate when I sedated a patient, I came forward and was like, "Hey, this is what I did. I gave too much," uh, and report to the doctor, report to my supervisor, and I wrote the report exactly how I did it. And my training officer was like, "Okay, you screwed up. What should we do about it?" And I was like, "Make me retake the RSI test, and what else you want me to do? Like, I'll do whatever you want me to do." And he's like, "I want you to teach RSI next month." And I was like, "Oh, okay." So I did. Next month, every single IC session in service, I retaught RSI. And like that was humbling, knowing that I just jacked it up and now I'm teaching it. But that's the way that people learn. Adult learners are going to learn that way, is by teaching. So, and now that I'm part time in the ambulance, I do a lot more office work than I do anything else. That's why I hand my drugs through the door. Like, hey, I need you to look at this and make sure I'm giving the right drug. Uh, I was on a call, it hasn't been that long ago. I'm working with a neuro paramedic, and I was like, "Hey, just confirm this drug dosage is this." And this young paramedic looks at me and was like, "Are you serious?" I'm like, "Yeah, confirm the dose for me." And he was like, "Is this a test?" I was like, "No, this is not a freaking test. Like, tell me the dose." He's like, "One is you're one of the training officers here, and you wrote the standing orders." I was like, "Yes, I've looked at 20 standing orders in the last year. I need you to confirm this doses." And he's like, "Yeah." I don't remember what it was now. He's like 5 milligrams. That's the correct dose. I was like, "Thank you." Like he thought it was a test. He was like all worried that I was like giving him a quiz. I'm like, "No, I'm legitimately asking to confirm the dose here, what this drug is before we mess up." So that's my feeling, is that it's going to drive that culture where people cover it up, they sweep it under a rug, they, I just don't think it's right. So I'm not happy about it, but there's nothing I can do about it. Just train our EMTs and paramedics to stick rights and do the best we can. But accidents will happen and do happen.
Yeah. And we have the same policy on the helicopter, where I can't give a med without confirming it with my nurse partner, and she can't give a med with, or he can't give it without confirming it with me. So like I'll drop 4 of Zofran. I've given thousands and thousands of milligrams of Zofran in my career. It is the easiest, most mundane med on the planet. And I always, hey, I drew up that. I show them the syringe. I show them the vial. I say, hey, 4 of Zofran and 2 mLs. Say, okay, great. Look at it. Give it. So it doesn't matter how mundane it is. We always do that. But I can't say that I've always done it. I've definitely been in rushes and pushed meds before. Like I didn't make an error, but things go by the wayside. And I think that's the thing here is that, one, the criminal conviction doesn't help anybody. Number 2, it drives a unhealthy culture within healthcare. The only kind of error we need to punish is, I think, what do they call it? Reckless, or it's something where like the person knows what they're doing is going to
Yeah, like if
result
I
in.
give you 150 of sucks just because you were an a-hole to me, and that's all I give you is 150 of
Yeah,
paralytic and let you go, yeah, then I'm going to jail for that.
yeah, that's like, and that's a different thing. But in this case, there was no criminal intent. Nobody's like, it's really a financial situation that's drawing criminal charges for somebody. And I just don't see this going in a good direction. You know, we're a very justice-based society. We really like to see people get their comeuppance, but at the end of the day, like, who does it help? Who does it hurt? And I think this will hurt more patients than putting this nurse away for 12 years. Who cares? She
Yeah.
can go about her life and, you know, struggle with, like, she has to live with that. Like, she got into healthcare to help people, and now she killed somebody. Like that can't be an easy burden to live with. So I think she's gotten enough punishment in that realm. But, you know, we'll see. Now there's 2, I don't think it's gone to trial yet, but there are 2 paramedics in Aurora, Colorado that are going for murder charges for a kid that they overdosed on ketamine. Now, whether, you know, kid ended up dying, very tragic. They did overdose him. You know, there's questions whether it was a needed med in that situation or not. They got really bad training from the beginning,
Mm,
which they found. This again happened in like 2017 or something. It's hugely drawn out. But now they're going to trial for a very similar thing. And I think if we get both of these convictions on these people, like, it sets the precedent. Like there's case law now. And um, that's pretty scary to me because that's even more scary because it was the right med. Well, might have been the right med in that case, but they meant to give that medication
yeah.
and they didn't overdose it that much. It has a big safety profile. Other things happened that were bad, but once again, I don't think it was criminal. So yeah, I'm a little bit worried to see where this goes. We already have a nursing shortage. We already have a paramedic shortage. And who wants to go into a profession where you make a mistake and you go to jail? Can you imagine if weathermen went to jail every time they were wrong? Like,
Yeah.
people make mistakes in their professional life, and that sucks in healthcare that it affects people. But I just don't see this being good.
Definitely. So that's why I think it's important to train our EMTs to know what medications are. This isn't just a paramedic skill, paramedic problem. Like I teach my EMTs, all right, this is what epi is given for. This is what atropine is given for. This is what Zofran is given for. Levofed, dopamine. Like this is all stuff. Um, like when I did orientation for EMT, I was like, hey, go to spike a bag, make sure it doesn't say dopamine on it. Like it needs to say normal saline, like sodium chloride. Like this is what it is. Like it can make it say LR. Like I'm okay with making that mistake. Saline versus LR, whatever. But it doesn't say dopamine, doesn't say lidocaine on it. So to kind of twist this back to the civilian side, I just, if you're giving your medications to maybe your dad, mom, you're giving like the little like pill boxes that have Monday through Sunday or whatever on those, then make sure you're giving the right drugs. Even on the civilian side, like we've been talking about the the professional side, and that's obviously something you should be aware of on the civilian medical side of it. But if you're giving medications to a grandfather, grandmother, double check those drugs that you're giving. Make sure it's not just it's always been in that style bottle or that's always been that white pill. Like things change. So if you're one of those caregivers that are giving medications to your loved ones, just double check those medications and make sure you're giving the right medication, that something didn't get changed. So that's my side for the civilian.
Yep. I completely agree. And I guess for those of you following the case, like really think it through, look at some other opinions because I think it's a little bit harder to see this point of view if you're out of healthcare. Like, of course, the healthcare providers don't think they should be prosecuted for anything. And I can definitely see the argument for the other side of this. But
Yep.
yeah, I think that pretty much sums up my opinions of it. The next thing, and bad things on the internet, once again, um, to look at is I just saw this video by a trooper with Vermont State Police, and nothing against this trooper whatsoever. Like he's doing what he was trained to do. He's doing good work most of the time, but his medical care is pretty lacking. And it's I realized when I posted this on Instagram that this was a myth that a lot of people didn't know. So the video shows a trooper coming up to his partner.
Hold
And
on,
they're
time out.
yeah.
I am sorry about almost getting you kicked off Instagram when I shared because the dude had made a fake account, and then you shared it for me, like, "Hey, go report this account," which I really appreciate you doing that. And then so I shared Prep Medic's story on Instagram, and so it looked like I was saying go report
Go
Prep
report
Medic's
this
shit.
dude. I was like, wait, I messaged him. I was
So
like, hey, it's making people report me, I think.
I got a lot of comments going, dude, you've taken this rivalry to a whole new level to get his Instagram shut down. So that's not what I was doing. So I do apologize about that. But Prep Medic was actually doing a good thing for me, trying to get an account shut down for me. And I almost got his account shut down. So anyway, I apologize. I digress. Go forward.
No, it's all good. Yeah. So report fake accounts. Don't report our real accounts. I was thinking, wow, that person looks a lot like Skinny Medic, and that looks a lot like Skinny Medic's wife. Turns out it wasn't. So
I'll scroll off one more time on that story. So we're talking about this fake account to my wife, and I was like, man, this jerk stole all my pictures of my guns and stuff. And like, I'm pretty ticked off about that. And she was like, hey, babe, do you know he stole the pictures of your wife and kids too? I was like, oh, crap. Didn't even notice that part. Yeah, he's a jerk. Don't steal my wife's pictures. So I got in trouble for that one.
you can steal Skinny Medic's wife before you can steal his guns.
Definitely.
That's how two-way Skinny Medic is.
Yeah, she's for sale. You can't have my guns.
Yeah. So this trooper comes up to his unsuspecting victim and he knee drops him. So a knee drop is putting your knee into somebody's groin, and the thought is that you're compressing their femoral artery and stopping, like slowing that blood flow down to give you more time to apply a tourniquet. And this was taught, up until pretty recently as a viable tactic. So, okay, yeah, it's kind of old science. And then he starts throwing on this tourniquet. I'm like, wow, that looks really skinny and green. And it turns out that it's a rat's tourniquet. And I thought, well, all right, it's just some guy being a cool dude, bought his own rats because a special operator said that it worked and it's fine. And I got a couple messages from some Vermont state troopers, and they were like, yeah, this is super freaking embarrassing. They're like, yeah, we get issued the rat's tourniquet and we are taught knee drops. And all of this turns out what came from Vermont state troopers. And I'm sure they do a good job. I don't know anything about the organization, but I'm going to go off the assumption that Vermont state troopers do a good job and are a professional service and serve and protect as they're supposed to do. But yeah, I think that's pretty not cool. That's the first large professional service I've ever seen using rats tourniquets and issuing them as a piece of gear.
Yeah, like I can't think of any like professional organization like police, fire, EMS, that's used the rats. I've seen on Instagram, things like that. I know a lot of people who will swear by the rats and they'll fight you over it. And I've done videos on them in the past, long time ago, and said basically that I would rather see you do the rats than a like a belt, things like that. Like they do
Absolutely.
work. Okay. We may disagree here, but I think the rats tourniquet works.
No, it does. And there's
you can
data
make
to
it a
support
tourniquet.
that it does work. It's not optimal, but it does work.
There's better tourniquets on the market. And it always comes up about kids. kids don't really need tourniquets. They need pressure bandages. You
Yep.
can reach and grab their arm. So the rats does work, in my opinion. I've done Doppler studies with the rats, and it cuts off blood flow. It hurts like a mother, but and in a calm environment in a laboratory with perfect lighting, perfect material, we were able to get blood flow pretty easily with the rats. But then again, when you're bloody down in a ditch in a side of the road, it's going to be difficult. And I think there's better tourniquets on the market for not that much more money. Uh, and yes, I've taught knee drops. Up until probably pre-COVID, we were teaching knee drops. Hey,
Yeah.
when you come up and you're getting your tourniquet off your vest, off your belt, out of your pocket, you're taking out the wrapper out of your kit, drop the knee down and slow down the bleeding. But we really have seen that it's not the best idea. It takes away from you actually getting the tourniquet on, and you're probably not doing a very good job of it anyway. And it's pretty complicated trying to keep your knee on someone while also trying to get something out of your vest, out of your pocket, out of your bag, and trying to keep good solid pressure on their femoral artery.
Yeah, a lot of people miss it. So it's a really small target, and your knee is not this big, large area of mass. So one, you're probably not going to do any good. It puts, like you said, it puts you out of position to put the tourniquet on. So your application is slower, which like the tourniquet application is why you're doing it. So now you're taking longer to get the tourniquet on, and you might have just exacerbated other injuries. If they had a pelvic injury, we can lose a lot of blood from the pelvis. You're amped up, you might come down a little bit harder than you wanted to and cause other injuries. I've seen a ton of people just hit somebody right in the balls with their knee, trying to do it. And that's just insult to injury.
That is kind of
At
fun to do, like just slide it in there real quick. Oh, sorry about that, buddy.
Oops. So yeah, it's just not it's not a taught technique. It really doesn't make sense. Just focus on getting that tourniquet on as fast as you can, next to them. If you have a buddy with you, they can go and they can apply direct pressure over that wound while you're getting the tourniquet on. I think that's completely acceptable. But pressure points, elevation, they used to teach when I went through EMT school, this steps for bleeding control were you try
What year
direct
was this?
pressure. 2010, I went through EMT school. 2012, I graduated paramedic school. I know. So it was pressure. You try pressure. If that didn't work, you'd elevate the extremity. If that didn't work, you'd elevate the extremity and you'd use a pressure point. And then you'd go to a tourniquet. And that's really just not good practice anymore. So that's bad. Rat's tourniquet, like you said, it can work. But it's one of those things where I give people the analogy of we used to do 3-1 CPR. So we do 3 compressions, 2 breaths. 2 breaths is 3-2. And then you do 3 compressions and 2 breaths. And guess what? That worked. It saved people. But if you did that now, that's completely unacceptable practice because we have things that work better. We have 30-2 and now compression only with advanced airways in place. So just because something works doesn't mean it's the optimal thing for you to do. And that's what I'd really take away from that is that there's really no reason for a rats when you have other things, especially for a trooper. Like the one argument for rats that I'll take, that I like, yeah, like, okay. Like it's the smallest, I think it's one of the smallest tourniquets on the market. I think you can put a rat's tourniquet almost anywhere. And I still wouldn't carry one. I think there's better options still, but I can see that you're a police officer. You got a duty belt. You can put a tourniquet holder anywhere, and you're probably wearing cargo pants, so you could even throw one in there. So there's really no excuse for compact in that case. And really, I think the state just kind of went with the cheapest option and
That's
said,
what
"Oh
bugs
yeah, that's
me.
good."
If you're an individual buying your own gear and people are like, "Hey, the rats is $10 versus the cat tourniquet's $30," I'm like, "All right, don't drink Starbucks twice a week and you can get your cat tourniquet." I get it, but budget is an issue. Money is not growing on trees, unfortunately. So I could understand the budget side of things, but this is a state agency that has multiple $1 million budget. I don't know their budget, Vermont State Police, but it's multiple millions, multi-million, I would assume. So for them to spend a couple thousand on cat tourniquets is a drop in the bucket. So that's pretty frustrating.
Yeah, absolutely. So those things don't need drop. Don't use rats tourniquets. If you want something for your dog, because that always comes up, get a SWAT T. That's actually what's recommended by Canine TECC. So that's a great, or just a pressure bandage. Pressure bandages work excellent for children and dogs. You don't need a tourniquet in those cases most of the time. So that's about all I have for that one.
Cool. The other one I saw, and I don't remember who posted it, to be honest with you. I think it was North American Rescue. But basically, they have a patient, it's overseas somewhere, that's got a mangled leg, it's amputated. They're working with it, it's bleeding. And then some guy's laying on the ground, like next to the guy's head, holding C spine. Um, and so I wanted to bring that one up as we're talking about things. A lot of people are scared about neck injuries. Oh, if you move them, you're going to cause them to be paralyzed, things like that. And there again, that is something we've taught for years. When I went through EMT paramedic school, we put this thing called a KED on them. It's a kinder education device. It was a great torture device. And we moved the patient like crazy trying to put it on just so we wouldn't move them, put them on a long spine board. And now we basically, oh, your neck and back hurt? Here's a collar. Get out of the car, have a seat on my stretcher. We're going to put you in a position of comfort, and we're going to give you rides to the hospital. We've seen the data shows that if you're going to have a accident, they're going to be paralyzed. It happens in the moment of impact, the moment of trauma, not when you go to move them out of the car, not when you move them up the ditch, not when you move them out of the hallway. It doesn't happen. So if you have a patient that's multi-trauma, meaning multiple systems are involved, the trauma system, and you have an amputation, like we were talking about this knee drop things, I don't need you to hold C-spine. I need you to help me get a tourniquet on. I need you to help me keep this red stuff on the inside. And that's important. So C-spine is not as important as we think it is. Now, if we have a guy who's like dove into a pool head first, maybe it's a different story. But this is a guy that has got an amputated leg. Like, quit holding the head. I need you to get down here and hold some pressure down here. Help me get gauze out. Help me get combat gauze, C-locks, get 2 tourniquets on, whatever I need. I need you to help me stop. Come down here to this end.
Yeah, and I agree. And for me, C-spine is always an afterthought. We still maintain it. It's still standard of care to maintain C-spine in a lot of different situations. Like guy dives into the pool, but even the guy that dives into the pool and somebody's there first and they're like, I don't want to get him out of the water because, I'm afraid I'm more worried about hypothermia. I'm more worried about airway issues. I'm more worried about the patient freaking out in the water. Like, drag the guy out. Yeah, try not to move his neck unceremoniously. Like, try to protect that a little bit, but I don't care if you have a C collar. Like, I don't care on the helicopter if I have a bunch of stuff. Like, yeah, we'll try to tape him to the cot. We'll minimize movement as much as possible. But for me, it's never a priority in my patients. I'm always worried about something else. And usually the ones that I focus on C-spine are the ones where there's no other issue. And they're like, I've got point tenderness in my C7. And those are the ones that like, yeah, okay, like we'll be careful. Let's put you in the vacuum mattress. Let's try this. But really, truly, I can't tell you the number of people that comment when I do like a kit build out and I'm walking through it, like, where's your C collar? It's like, I don't care about C collars. I don't carry one in any of my SWAT gear. There's one in the truck, but I'd have to dig for it to find it. Like, I don't carry it on anything search and rescue related. Sometimes with this scoop stretcher that comes, I'll have one, but it's just not that big of a deal, in my opinion. And obviously follow your own local protocols, procedures and stuff. And you should never try to like manipulate somebody's neck or, do all of these things or, have them move excessively. But the days of doing like you have somebody out of the car and you do a standing takedown. So you
That
put
was
the
so
backboard
cool.
behind them. It always felt cool to do it. You like have somebody hold stabilization and then you lower the backboard to the ground and you secure them with webbing. And they can't move more than an inch when you roll them in either side. Like, the days of that are over. And if
Yes.
your service is still doing that, I am so sorry, and you should talk to somebody.
Yes. But yeah, like I got tested on that. Like when I test my paramedic, like we had to make sure we put someone on a backboard properly, and you properly size that C collar. They're not everybody's a no neck, and there may be a regular or a tall, but we had to do that, and so those days are done. And so I'm glad to see it. And like we kind of talk about that. If someone's in a car, they're complaining neck and back pain, and I have multiple patients, I'm like, cool, just keep looking ahead. Like, look at the speedometer, look at the steering wheel. I'll be back. That's maintaining C-spine. They're doing it themselves. I don't have to go hold their neck. And we've done it. Like, I've crawled in a car and like held C-spine. Like, all right, guys, I've got C-spine. We don't have to do that anymore. And we're learning. They're practicing medicine. So, yeah, you don't have to be worried about it. Move the patient if there's life threatening things like that. We can absolutely move them. Like we're saying, in the pool, don't have their head make a circle, but at least be cautious about it. But don't freak out about it.
Yeah. Actually, there was a nurse not too long ago that she missed an airway because of the patient was in a C collar. And we debriefed it. Like it was one of her first pre-hospital tubes. And it all's well that ends well. She did everything she was supposed to do, missed the tube, reevaluated what she was doing, came back and ended up getting the tube. The patient never desaturated, like no harmful outcome. She troubleshooted the airway just as she should have. But it came out in debrief that they're like, well, why? Like, she's like, well, I missed it because there was a C collar in place. And then we kind of went through with the medical director and it was, well, why was there a C collar in place still? Like, take the C collar off. Somebody can hold it, sure, from the front and help you do a jaw thrust. Yeah, we probably want to avoid hyperextending, but what's more important, the potential of a spinal injury or the guaranteed airway compromise that you're intubating this patient for? So yeah, and the guidance from our doctor was, listen, do C-spine when it's feasible. Otherwise, get everything else done first.
Yeah, that's kind of like if I'm going to RSI somebody or get a tube on a terminal patient, I'm going to pop that collar loose because I'm not moving their head lateral, like left to right. I'm basically going in, and we use the video laryngoscope too, so I'm moving the jaw just a little bit, and I'm going to get the tube. So, and then I'll put the collar back on. But yeah, I'm going to take the collar off. I hate them.
Yeah. So, yeah, I don't care about C-spine. And beyond that, shortages are coming back, I hear, and your business in particular is getting hit with some shortages that I'm sure is pissing a couple people off.
Definitely. We are getting bombarded with emails, and it is what it is. Like, we're trying to do the best we can for our customers, but we're in supply chain shortage, if you haven't heard. And before, everybody wanted an N95 mask, and we couldn't get them, but now we got them. And for some reason, trauma supplies have went nuts. And I would assume it's because of the war going on in Ukraine versus Russia, but it's affected our stuff here. So combat gauze, C-locks, all those items are back ordered from the manufacturer. Like, we have cases on order from the manufacturer. North American Rescue is back ordered. Everybody, there is no combat gauze to be found on the internet. Trust me, I've tried to find it. But yeah, so I appreciate everybody's patience. We've had only like one customer that got flipped out on us, but most of them are understanding. Like, it's just a thing that we're having to live through. So I appreciate everybody's support over there and the understanding that we'll get your order out as soon as we can. So we should have more combat gauze in next week or two.
And on that note, I will sell anybody listening to this 3 things of combat gauze for $2,500. Ships today. I'll even do overnight for you. Just throwing that out there if anybody does want combat gauze.
Yeah, you can give them your email address or your phone number. They can text you.
Perfect. How about just the address? Let's just go with the address.
Yeah, if you send me an email, I'll give you Prep Medic's phone number, and you can text him all you want to, and you can get that. So if you sell combat gauze for $2,000, I'll sell you Prep Medic's phone number for $1,000.
Ooh, interesting. We're getting it coming and going. I'm just about as good at responding to calls and texts as I am at responding to DMs. So don't expect anything.
True story. I can show you. I'm like, hey, are you still alive? Are you breathing?
Recording?
Yeah. Hey, what do you want to do? We haven't recorded in a month. Hey, do you want to do this? So it's not like you're super busy. Like, you got a brand new kid. You're trying to be a flight medic, be a SWAT medic, and try to figure out how to carry a gun. And you're a little busy.
Some things. I don't know. I just leash him out. I leash my kid out back and give him a bowl of food in the morning. He self-feeds. It's fine.
That's perfect. Yeah. You can send him over to my house. I will get him packing orders pretty quick. So if he can count to 10, he can pack orders. So we'll get him over here.
Perfect.
Awesome. Anything else from you?
No, that's all I got.
Awesome. That's all I got. I appreciate you guys. Thank you for subscribing on the podcast area, basically on all the apps that you can download podcasts on. We're there. So I appreciate the support over there. We're also recording videos now and putting them on the YouTube channel, Civilian Medical Podcast over on YouTube. We're just shy of 1,000 subscribers, so that was our first kind of goal, was to get to 1,000. So we're almost there. Hopefully soon we will schedule a live chat, which I think should be fairly interesting. The questions are going to come in. So I appreciate all you guys' support. Thank you guys. We will see you in a week or two.